This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Acta Neurochirurgica, published in 2026. The paper is titled, How I Do It, Microvascular Decompression for Vago-Glossopharyngeal Neuralgia, authored by Andre Brunzu and colleagues.
It's a great choice, Ilara. While we perform trigeminal neuralgia decompressions quite frequently, glossopharyngeal neuralgia, or as the authors more accurately term it, vago-glossopharyngeal neuralgia, or VGN, is a different beast entirely. It's quite rare, isn't it?
Exactly. The paper notes that VGN represents only about 0.2 to 1.3% of facial pain syndromes. To put that in perspective for our residents listening, trigeminal neuralgia accounts for about 80 to 90%. So even in a high-volume center, you might only see a handful of these cases a year.
And because it's rare, the surgical nuances are even more critical to discuss. When medication fails, microvascular decompression, or MVD, is regarded as the most effective and durable therapeutic option, provided a neurovascular conflict is demonstrated on high-resolution MRI. Before we get into the how-to, let's talk about the why regarding the anatomy the authors highlight.
Right. The paper emphasizes the intimate arrangement of the lower cranial nerves. The glossopharyngeal rootlets, usually numbering 1 to 4, emerge from the rostral portion of the post-olivary sulcus. Immediately caudal to that, the vagus nerve arises through a longer series of 8 to 10 rootlets along that same sulcus.
And they both converge toward the jugular foramen to enter its pars nervosa. This proximity is why the authors call it vago-glossopharyngeal neuralgia. A vascular conflict, often from the posterior inferior cerebellar artery, PICA, or a megadolicovertebro-basilar artery, often hits both nerves simultaneously.
Which brings us to the preoperative planning. The authors are very specific about the imaging protocols. They recommend high-resolution MRI with T2-weighted CISS, Fiesta, or drive sequences.
Those are essential for seeing the conflict itself, but they also mention T1 post-gadolinium to depict veins and 3D time of flight, or TOF, angiography to characterize the arteries. They even mention fusion imaging to enhance detection. But beyond the imaging, there are 2 clinical consultations they insist on. Do you remember those?
Yes, an otolaryngology consultation is deemed essential to rule out local pathologies that might mimic GN. They also advocate for a baseline auditory function evaluation. More interestingly, because VGN can be associated with syncopal episodes, all patients must undergo a systematic cardiac evaluation.
That's a vital safety point. If a patient is bradycardic or fainting during a pain paroxysm, you need to know that going in. Now, let's move into the OR. For anesthesia, the authors prefer TIVA, total intravenous anesthesia, using propofol and remifentanil.
And they mention a specific tip for cerebellar relaxation, limiting end expiratory pressure to lower the central venous pressure. They also suggest restricting neuromuscular blockade to the induction phase only. Why is that?
Because we need to monitor those lower cranial nerves intraoperatively. If the patient is paralyzed, your monitoring won't give you the feedback you need if you're putting traction on CN9 or CN10. They also suggest brainstem auditory evoked potentials, especially during the surgical learning curve. Now, let's talk positioning. This isn't your standard park bench, is it?
They describe a lateral decubitus position, but with the patient slightly rotated backwards so the shoulder falls toward the surgeon. They use a back support at the inferior tip of the scapulae and elevate the torso about 10 degrees to help with venous return.
The head positioning is also quite precise. They use a 3-pin head holder, 1 pin above the ipsilateral eyebrow and 2 on the contralateral occipital bone. The head is slightly flexed, keeping the chin about 2 finger breadths from the sternum and rotated contralaterally. They also emphasize a slight lateral flexion to prevent the shoulder from obstructing the surgical corridor.
I liked the detail about the shoulder. They gently pull it caudally using a strap, though they warn to avoid excessive brachial plexus traction. Once they are positioned, the incision is planned posterior to the auricle, inferior to the osteorenal region, and extended down toward the mastoid tip.
This sets up a caudal retrosigmoid craniectomy. In terms of the actual exposure, they perform a subperiosteal dissection to expose the retrosigmoid region and the mastoid tip. They mention that if you hit the occipital artery, you ligate it, but if you find the great occipital nerve, you should mobilize it rather than sectioning it to avoid neuropathic pain.
The craniectomy itself is described as keyhole size, right at the level of the mastoid tip. They aim to expose the edge of the sigmoid sinus as caudally as possible, over a length of about 3 centimeters. Any mastoid cells that get opened are immediately occluded to prevent a CSF leak.
And then the dura is opened in a curvilinear fashion, reflected toward the sigmoid sinus, and suspended. This is where the infrafloccular approach really starts. Ilara, walk us through the initial intradural steps.
Once the dura is opened, they focus on releasing CSF from the cisterna magna. This is the gold standard for getting the cerebella to relax without heavy retraction. Once that's done, they place a self-retaining retractor, specifically mentioning narrow, malleable sagitta blades, on the lateral surface of the cerebellar tonsil.
Note the placement, the lateral surface of the tonsil. This creates a corridor beneath the flocculus, heading straight toward the retroolivary sulcus. They emphasize that the retractor should exert only minimal pressure.
Once they have that corridor, they use bayonet scissors for sharp dissection of the arachnoid membranes. This is where they identify the glossopharyngeal and vagus rootlets. They use a dissector probe to mobilize the vascular loops.
This is the critical moment. The paper notes that pica is the most common culprit, but they frequently see a compressive megadolicovertebral basilar artery involved as well. The goal is to relieve the conflict either through vessel transposition or Teflon interposition.
For the interposition, they mention using polytetrafluoroethylene, better known as PTFE or Teflon. They say it can be either shredded or knitted, which is currently the most used material, though they mention polyester Dacron is rarely utilized.
It's important for the listeners to visualize the depth of this. You're working at the lateral medulla and the root entry zone of these lower cranial nerves. The paper stresses using fine bipolar forceps for precise hemostasis with minimal thermal spread, which is vital when you're millimeters away from the brainstem and the nuclei of the lower nerves.
They also mention the importance of the infrafloccular orientation. By staying below the flocculus, you have the best trajectory to see the 9-10 complex as it enters the jugular foramen. If you're too high, you're looking at the 7-8 complex, which isn't the goal here and puts those nerves at unnecessary risk.
Exactly. The how I do it approach here is really about a safe, reproducible corridor. By utilizing the cisterna magna for relaxation and a caudal retrosigmoid opening, you minimize the need for aggressive cerebellar retraction, which is often the source of postoperative complications in these posterior fossa cases.
The authors conclude by stating that when these steps are followed, from the high-resolution MRI planning to the specific lateral decubitus positioning and the infrafloccular approach, MVD for Vago-Glossopharyngeal Neuralgia can be achieved with optimal efficacy and safety.
It's a specialized procedure for a rare condition, but the principles of microsurgery remain the same: clear visualization, sharp dissection, and minimal tension on neural structures.
Definitely. It's a great reminder that even for the rarest neuralgias, a systematic surgical technique is key.
Well, that's all the time we have for this deep dive into the 2026 Brinzu paper on Vago-Glossopharyngeal Neuralgia. Thanks for joining us on the Neurosurgery Hub podcast. We'll see you next time.
Goodbye.